I am recording, but people are still joining.
So Nora, I think you can go.
Okay, thanks everybody for joining us for this Division Director's Town Hall. I'm Nora Singer, and we're fortunate to have Tim Laing with us today. Just a couple of housekeeping details before we get started. All the attendees are muted throughout the webinar. We'll review your questions and present them to the lecturer at the end of the presentation. And then after all the Q&A, all the questions in the Q&A are answered, we will open it up and people can unmute to ask direct questions. The chat can be used to make general comments that everyone can see. Raise your hand if you're having some issue that you need the ACR staff to address, please. And then we are also going to record this lecture. Okay, so we got a lot of questions about RVUs, especially with the new RVUs changing value. This is Jack Welch in the picture, and he's the former head of GE, who is really responsible in many ways for the development of RVUs and the corporatization of American medical care. And really, Jack Welch, to get GE to perform, basically said, you know, treat your top 20% really well, the 70% in the middle, okay, and get rid of the bottom people. But it's really those 20% of top talent that you want to retain. So he had many, you'll see throughout, I think, American medicine now, many of the hypotheses or management styles that Jack Welch had have really gotten incorporated into American medical care. Next slide. And so Tim Laing, who most of you know, is here to help us reduce to practice what's just happened with RVUs and really understand it. Tim did his undergraduate work at Harvard. He did medical school at the University of Michigan, as well as residency, and then went to UCSF for fellowship and came back in 1988 as faculty, where I met him during my residency and while I was a fellow at Michigan. So I feel very fortunate to invite Tim Laing. Many of you know him through his work with the AMA and on the RUC committee, and he'll explain most of that in the next hour. Tim?
So I'm going to press.
I think you're muted.
Okay, so this is where I share my screen, and hopefully this will work. I'm going to press the button. Scary because I'm old. Let's see. Okay. Whoa. Here we go. So, hi everybody. So you've already seen this slide. So let me see if I can advance my slides. Yay! I did. So I was asked to talk about how we got to where we're at with the current changes that came out for this past calendar year. And so what I've done is taken, cannibalized some slides from grand rounds I did earlier this year for my institution. And I sent that grand rounds to Nora, and you're welcome, and Nora, you're welcome to circulate that to everybody if you like. It's a fuller version of what I'm about to go through now. I've just pulled out a couple of slides because I think I got the impression that what you really wanted to do was reserve some time to talk about the fact that
Tim, some people can't see your slides, it appears.
Well, I don't know how to.
They're showing on my end.
Don't know how to fix that, but I'll wait.
Are there other people having trouble seeing the slides? If you just put in the chat if you are. Okay. Okay, so I think we're okay to keep going.
Okay, and how's the audio? Audio is okay?
Yes.
Okay, so as I was saying, I cannibalized these slides from a grand rounds that I gave at our institution earlier this year, and it's a more in-depth version of where the professional fee schedule for this year came from historically. And I sent that deck to Nora. You're welcome. She's welcome to circulate that to the group if you like. It's a more fuller version of what I'm about to go through. This could be a little telegraphic, but I know you wanted to talk about really the issue of what CMS did versus what's actually happening out in practice. And so I don't want to take away from that discussion. So I don't have any disclosures. To sort of characterize where we're at now as a profession, I thought it was interesting. My good friend and colleague, John Goodson at Harvard, put together a paper earlier this year which looked at what's happening across the country in terms of higher paid specialties and lower paid specialties. So the lower paid specialties, of which we're in the middle on the right panel, are characterized versus the higher paid specialties on the left side. And the numbers on the top of the bars represent the number of counties that don't have any one of those specialties in their county in the United States. So a high number is bad and a low number is good. And essentially what he showed was that the higher paid specialties are more uniformly distributed throughout the US versus the lower paid specialties. And then I also threw in a slide here about burnout. And guess what? Here we are right at the top. And you know, if you take another look at this, you just realize that burnout is something that's become endemic to our profession. So as a background to this whole presentation around how physicians are compensated, I think the bottom line is in America, we have an imbalance in our workforce. And we also know through the research that's been done, the papers that have been published by members of our own society, that in the coming years, the workforce imbalance is going to get worse and the shortage is going to get worse. But in the meantime, we've got this burnout issue. So compensation, while it's not the only thing that governs what people choose as specialties, of course, is certainly an important factor and something that we need to really think hard about. And I think, unfortunately, what we're seeing this year is that despite some of the changes that are coming down the tracks, the translation of that isn't really occurring the way we would want it to. So, you know, where did all this come from? So, in the way back when, let me see if I can move my screen around a little bit so I can see my own slides. Sorry. In the beginning, physicians were paid on usual and customary. And CMS, when it came on the scene, starting when Medicare came out in 1965, a little bit of trivia here, if I may. Well, you probably can't raise your hand if you know who got the first two Medicare cards. Anybody know that? So the answer is in this quiz is Harry Truman and his wife. So isn't that interesting? Anyway. In 1985, Congress decided that they wanted to give CMS something that was a little more organized for physician payment. And they commissioned Bill Shao at Harvard to do a very, very large study to figure out how to make a resource-based relative value scale that would create some way to create a relativity between the different procedures that were done by physicians and make a rational payment system. And that study was a success, and that's what we have now. It was subsequently adopted by all the payers in the US. So it's a big deal. And those two landmark papers came out in 1988. And essentially what Bill and his group did was create a formula, the equivalent of E equals MC squared, to create the basis of what we now know as relative value units. And interestingly, they looked at total work, they looked at malpractice costs, that's the RPC factor, and they looked at 1 plus AST, which was a factor that was a surrogate for training and experience. And that, you know, as a lot of times happens, something that happens in academia, when it gets translated into legislation, things get lost in translation, and that particular factor got lost in translation. That was the one factor that might have given us a leg up on saying expertise matters, but that went away. But that's okay, so let's keep going. In 1989, this Budget Act switched CMS over to RVUs. And wouldn't you know it, in 1991, CMS looked at this. Oh gosh, what did I do? What did I do? No. CMS looked at this, and the AMA was ready. The AMA had already gotten the rights to the CPT manual, and the AMA said, we're ready to work on creating updates for this. And then the whole system was mandated in 1992, and everybody went over to RVUs. So prior to that, there was a lot of political pressure out there. Fee for service was being looked at as something that was bad, and even back then, and so spending caps, capitation, other things were being talked about. And so then that's where the AMA said, okay, that's fine, we'll accept this RVUs. And they also, as you can see here in bold here, they agreed to forego balanced billing. So if you go to your dentist and your insurance pays $25 for teeth cleaning and your dentist wants $150, you owe him $125. And that's why to this day, that doesn't work for us. It's illegal to send a patient a bill in addition to what you have. So that was one avenue where potentially expertise could have been recognized, but that is not allowable under current regulation. But they did that in order to, because Congress was threatening other things. So they said, okay, we'll take softer expenditure targets and practice guidelines and whatnot in order to take this as opposed to what could have been much worse. At that time, the CPT was 7,000 codes. It's over 10,000 now. And the Physician Payment Review Committee was in charge with revising this on a regular basis. They realized that that was crazy. They couldn't do it. The AMA said, we can do it. And so the RUC, the Relative Value Unit Committee, of which I'm a member, was adopted. And there's another whole line of discussion that you can go through about Fox and Henhouse and that sort of thing. But for the sake of brevity, let me just say that's the current situation that we have, where this committee advises Medicare voluntarily, but this committee, basically the recommendations it makes year in and year out, 80% of them are adopted by Medicare. Interestingly enough, when Shao's paper came out, they projected what would happen to the various specialties. And you know, again, there's another lesson in what doesn't translate sometimes from academia to legislation. You can see on the left side, thoracic surgery, that's TS, would have been cut in half when you looked at Shao's models, and internal medicine over here on the right would have gotten a huge boost. But of course, when RVUs was adopted, all these changes were muted, and I guess that's kind of a foreshadowing of the discussion that we're going to have a little bit later on here this evening. RVUs, the current formula for RVUs is the work RVU plus the practice expense plus the malpractice expense gives the total RVU. The work RVU, much to my consternation in terms of trying to value our services, was valued in a way that really lends itself to valuing surgical procedures. Work RVU is solely a function of the product of time and intensity. And intensity is defined as the sum total of technical skill, physical effort, mental effort and judgment, psychological stress. So in essence, when a surgical procedure is tough and makes you worry a lot, takes a lot of training, you get a higher number, and then when you multiply that by the time, you get an even higher number. And that doesn't, I don't think, translate always to what we do, because what we do sometimes is walk into a room where several physicians have been unable to render a diagnosis, and we can do it, and it's not particularly stressful. It's by virtue of our experience. We often know things that other folks don't. That's why we're quote unquote specialists. It's not unique to rheumatology. Other specialists do the same thing. But all I'm trying to point out here is that the way that the Shao study was translated into RVUs lends itself to procedural kinds of work, doesn't necessarily lend itself to evaluation and management work. And so it's quite legitimate to ask whether or not evaluation and management services are truly fairly valued. The way the RUC and CPT work is this cycle of life, if you will. CPT, Current Procedural Terminology Committee, of which the AMA owns the rights to and generates over $100 million a year in royalties. The CPT is where new codes are created and existing codes are modified. When those are changed or created, surveys are created. The various specialty societies get involved in surveying their members, and then the results of those surveys come to the RUC, where on a 3 times a year basis, the RUC meets and creates a recommended value for those committees. That's forwarded or offered to, God, what did I do? Did I stop sharing? Tell me I did stop sharing. No, I didn't.
We're seeing a black screen right now. There, it's
okay.
back.
All right, sorry. So that goes to CMS, and 80% of the time, CMS translates that into the Medicare payment schedule. And I apologize if color's on that slide or not. So, as you know, this year, the values for the E&Ms went up a lot. This slide is to show you that they could have gone up even more, because CMS decided that the RUC, although it revalued the outpatient E&M services, could have done even better, and they proposed a modifier, G2211, for all the things that didn't really go into what the deliberations that the RUC carried out. And that basically would have meant another third of an RVU for every single E&M that all of us use, both new and out and return visit codes. But this is an example of the politics of medicine. When the continuing resolution bill came out at the end of in December 2020, CMS was said, I'm sorry, you can't do that. It's going to be delayed for 3 years. So, and I could go into more examples of this, but let me just say the politics of medicine are ferocious. They are ferocious, and it is good for all of us to heed that. So that said, we got a lot of good news. In addition to increasing the values, the E&M levels are now determined solely by medical decision making. The amount of time that was the amount of time has been modified, but the amount of time that you can count if you want to bill by time is all of the time on the date of service, even non-face-to-face. So the time you're getting ready to see the patient, the time after you see the patient, that all counts. All those hateful 95 and 97 bullet guidelines went away, and there's several new codes were developed to account for the time between visits. And we now have chronic care management codes, critical chronic care management codes, transitional care management codes, and soon to come, I hope, a principal care management code that's meant for specialists. And we had in the previous administration, we'll see with the current administration, hopefully will continue, solid support from CMS. And I should say, the other reason this topic is so vitally important for us is that there's the rest of all the E&Ms are being reconsidered. So the rest of the families are being considered as well. And if you want, I could go into a little bit of the politics of this, But basically, the other E&M, the inpatient E&Ms are coming out. Consult codes, which were taken away by CMS unilaterally several years ago, are being reconsidered as well. So there's a lot of potential increase for folks who live on the E&M side, as we do. And here's an example of what came out. Here's a table that Antenia sent that summarizes the changes for this current year. You can see the new patient codes here are 99201 through 99205. The return visits are 211 through 215. You can see the percentage increases on the right, and they're pretty significant, especially for the return visits. And the AMA went through and summarized the impact of all of this for all the specialties, and I pulled out on the next slide here the impact for rheumatology. The original conversion factor that was going to be used would have given us a 15% boost, but overall, with the revision, again, when some of the folks who were going to be hurt, that is to say the procedural-based specialties, chimed in, that was revised a bit. So now we're due really for a 13% impact. And that is what I had prepared, but I'm happy to stay and add to the discussion as you wish.
So one of the questions that arose, Tim, was how different institutions are handling this. So my own institution is crediting us with the work RVUs, but has more or less frozen salaries till they see the effect. It would be interesting to hear from you and others about how that has rolled out.
Right, and there was a survey. I wonder, has anyone summarized the survey that went out, the survey results that went out? I can tell you while you're looking to see that, in our institution, there was kind of a hybrid approach, as some of the survey respondents seemed to indicate. We got, the chairs got together and realized that that they didn't feel that the surgical cuts would be sustainable, no pun intended. And so we ended up with less than what you see here, but more than we had.
So we do have some of the survey results. Connie, do you want to pull up a few of those?
Let me stop here. Yeah.
See, do we want to pull up? Okay, so as you can see, many of you were surveyed. I think we got about a 20% response rate to the survey. And the answers about whether or not people received RVU visits and increased RVUs and whether or not salaries were frozen, you can see very tremendously between the institutions. I think, Eric, can you open up, I think Leslie had a comment and Eric Ruderman had a comment. Can we open up, can we unmute people so we can hear from them as well?
So if you have a comment, just, there you go, Eric. I can unmute you. Eric? Hold on.
I tried to unmute. Am I now unmuted?
Yes, you are.
Okay. Okay. I'm glad we're having this discussion because I really want to find out what other places are doing because I'm kind of frustrated by what's happened at our institution in response to this. So I just put it in the chat. So basically, our rheumatologists were quite excited because, you know, appropriately, the ACR had sort of sent out lots of messaging in the past year that this was coming based on the work, Tim, that you and your colleagues have done. And we were disappointed about a month or two into the new year to find out that we weren't actually getting credited with these new RVU numbers, that they had made a decision without actually disseminating the decision widely to basically stick with the old numbers and reconstruct it on the back end until September 1st, which is the fiscal year. And the reason they gave was that it would be too expensive to give us the new numbers, which I think means they didn't want to push back against the surgeons and take it away, because it's a zero-sum game. We go up, they go down. So that was clear. Now what we've heard, and we still don't have numbers, but what we're understanding is that as of September 1st, we will get the new numbers, but they're going to rejigger the dollars per RVU that are used to determine our compensation to basically set us back to where we were. That in other words, instead of going, they'll drop that by the corresponding 13% or 15% or whatever it is, so that our net compensation stays the same until perhaps a year or 2 years down the road, when they look at market numbers and recognize that rheumatologists in the community are actually reaping the benefits of this right away, that maybe they'll come back and change it. And again, the essential reason given was that it would be too expensive to give us what we're deserving. And again, I think that the reason behind that is that they don't want to push back against the surgeons and the proceduralists. I asked a number of times, why this would be, and could we have some further discussion on this? And I was eventually told by the chairman of the Department of Medicine to just stop asking, that this is what was going to happen, and too bad, basically. And so I'm curious as to whether other institutions are struggling with this same issue, because they all read the same white papers. The administrations at all our places read the same, consultant guidelines that are basically saying, well, this is what you can do, because otherwise you're going to have to somehow push back against the surgeons. And I'm just curious what other places are doing, and
Leslie,
if there
do you wanna...
is some, if there's some leverage that we can bring to bear from the ACR on institutions who are behaving this way, because this was obviously a change that was intended to sort of right a long-standing wrong, and now it's just being perpetuated.
Leslie, you had something, you put something in the Q&A. Do you want to chime in with how your institution has handled it?
Yeah. Can you hear me?
Yes.
Oh, okay. All right. So, and my dog is here and probably will bark, so sorry about that. Tim, first, thank you for that great presentation. I always appreciate your insights. So, Eric, something very similar happened here. At the beginning of the year, we were told that they would do a 6-month evaluation about the implications for the RVU change on salaries. And I got about a month ago, a few weeks ago, I got a new spreadsheet that essentially they've done the same thing that they did at Northwestern, which is they've essentially frozen salaries. They have actually increased the benchmark WRVUs. So where we used to be about 5,500, I think it's now something like 6,200, because they wanted to rebalance the benchmark WRVUs to the new numbers. And they decreased the dollar per RVU. And we had just had an increase in the dollar per RVU last year to increase the salaries for all our clinicians. And now they've decreased the dollars per RVU to freeze salaries where they are. So very similar approach. They're prioritizing maintaining salaries at the level that they previously were, and kind of changing the benchmark numbers to make that work. So similar, very similar to what's happening at Northwestern is happening here.
I think, Connie, can we unmute Peter, or Robin, can we unmute Peter Merkel? I think he has some experience to share as well.
Can you hear me now?
Yes.
Hi, this is Peter Merkel from Penn. First of all, Tim Laing, thank you very much. That was terrific. you share the slides, it'd be even better. I'm a little depressed about the burnout and suicide slide, but I think it's important as we are advocating internally. So Penn's done something a little similar to what Leslie described. Vandy is they have raised our RVU targets. We're normally at the 65th UHC, and whatever they call UHC this week. And they've sort of applied the idea that if we had the same level of 4s and 5s and 3s, then they converted it to what they should be now, for that's the new target. Although they actually did allow for a salary increase, and we're even advocating for more salary increases for our junior faculty. So they separate those issues. The problem is, not only is that a zero sum, we don't go higher, it's unlikely we will achieve that particular formulation because many of our 5s will now be 4s, and we had a high level of 5s in follow-ups, very high level, because we were good at it, whatever, and we were audited and we're fine. So we're going to actually not be able to make that. They sort of know that. We've actually been surveying from January through June, and we're trying to see if we can maximize. But it seems to me that's already a problem, and I wonder how UHC and other benchmarks will be making changes as well, because I can understand keeping us even, and then, which is not necessarily unreasonable, so because we're working within a system, but there is going to be, for us, we're going to actually have many more 4s and fewer 5s, and it doesn't even out. And I wonder if others are facing similar problems at highly complex practices. I think it's different when you're out private practice. I think it's different at different practices.
So I have one answer to that, which is often we communicate with other physicians. And so when there's communication with other physicians and independent review of data, it's my read at least that does get you to a 5.
That is true.
Well, regardless of that, I mean, I think there'll be changes, and I think that it's just interesting that they just sort of translate it. I think they're going to readjust, but there will be institutions that will not make that, and so I guess we'll have to sort of see how it all pans out.
Right, and I think that, I don't know about the rest of the institutions, we actually use a rolling 3-year benchmark.
Yeah, we do that too, yeah.
And I've not seen them renege on that yet at our institution, though I think that's possible at any point that could happen. But they have essentially frozen salaries. They haven't said they're freezing salaries, but that's what they've done in practice.
I might add, in terms of
Several people
productivity
in the chat. Oh, Tim, you wanted to say something?
No, just in terms of productivity, another change I haven't seen happen in our institution, the documentation requirements were changed radically, but most of my colleagues are still generating 4-page notes. In theory, you could see more patients in less time, but I haven't seen that at all.
And do you think that's just EHR bloat, that they have a template and they just pull everything in? We've tried to instruct our fellows. Yeah,
everyone's afraid not to put everything in the kitchen sink into their history and physical before they get to their medical decision making.
I think we have a couple of.
That's a change that I think we could communicate more effectively.
So there was a question about benchmarks. I know we used a AAMC weighted benchmark with MGMA. I'm not sure what other academic institutions are using. Do you know what you guys use, Tim? And can we hear from some other people?
MGMA, I think. But by the time it gets translated into actual practice, it's, as you're hearing, it's a pachinko palace. The money bounces around inside and gets changed around so that it equals the salaries that people think they should pay. And the changes that come out, that have come out like this, have not really translated into our internal system.
And I think that Dr. Laura wanted to be unmuted. Christine? Chris? Robin, can we unmute Chris Laura, please?
I must have hit the wrong button. No.
Okay, you're good.
Chris, did you have something you wanted to contribute?
No, I said I think I hit the wrong button.
Oh, sorry. Okay. Okay. So, because Mattia had FPSC, I'm not sure I know what that stands for. Leslie just put in the chat that they went from a benchmark for work RVUs from 522 to 66,027 for a full-time clinician, I assume. And did they, Leslie?
Yes, that's right.
Did they base that on any precedent?
I have no idea. I just got this about a week ago and I'm still kind of digging into it. But the bottom line is that I think what they did is they adjusted the WRVUs from past to WRVUs from present, looked at all of the data from all of the rheumatologists and said, okay, well, with the new kind of work RVUs per code, this is how it is adjusted. And so those are the exact numbers at my institution and how they were changed as of last week when I got the new information. So
and I don't know if
it's helpful to anybody.
Has had that experience.
That's what happened for us. Excuse me?
I don't know if anybody else has had that same experience of having the work RVU target moved as the reimbursement in terms of the numbers of work RVUs was being moved.
And by the way, Nora, let me comment that this was based on the reimbursement as well. So what's happened in Tennessee is that no matter what CMS has said, that the actual reimbursement by the insurance companies hasn't really changed very much. So what they did was they went and they evaluated the amount, based on all of our contracts with all of the insurance companies, what the reimbursement would be. And the rationale that I've gotten thus far, and I don't know whether other people have gotten had similar discussions with their institutions, is that until the reimbursement goes up for the insurance companies, that they're not going to make any changes in our reimbursement until we start seeing increased revenue for our services based on what the insurance companies are paying.
Joel, did you want to? So there are several senior people who've been division chiefs for a long time. I can see on the call. Could we hear from them too? I see at least 5 or 6 of them about what's gone on in different parts of the country.
Somebody asked me, so I'll just pipe in. Nothing different than what I've already heard from Peter and from Eric. As the RVU goes up, the demands are higher on us. So this year, like at Northwestern and Penn, they've nullified the increase, and they have not given us our new targets because they're still trying to determine the new targets. But the key part is exactly what Peter said, and that is that our 5s frequently are turning into 4s. So even though the RVU is higher, the reimbursement is higher, the actual total RVUs we get starts going down.
And is that other people's experience too, as you've seen the RVUs over the years? Dave or Rich, do you want to jump in and share your experience?
Am I unmuted?
You're unmuted, Rich. Thanks.
All right, so we have about 60 rheumatologists at Northwell in different walks of life. We have community doctors, we have academic doctors, we have research, and I have not heard a thing at all. So we all have targets. The target is around 5,200, 5,300 RVUs. And then the academic people get discounts for, various things that they do. On top of that, there's augmentation when one exceeds that value. And they have not augmented so far for the first quarter. They're a bit behind, whether it's because of this or something else, I don't know. So at least nothing has been done that I know of. It may be in the works behind my back, but it's business as usual right now. And overall, we've seen about a 20% increase in our total RVUs across the rheumatology network.
They have not dropped your RVU reimbursement.
They have not. We have, well, not everybody, but most of us have contracts, 3-year contracts, and I'm not sure they can really fool with those.
So a different model, perhaps, from some of the other places. How about in Texas? Dave, can you give us any insight as to what you've seen or other institutions in the West?
So am I on?
We can hear you.
Great. I was just typing something, but I'll let you know what's happened here. It's really not possible for me to track this very easily because they spent the last year sort of agnostic to the changes in RVUs, just reconfiguring our clinician educator compensation plan completely and raising the RVU percentage target so that a traditional, if you will, clinician educator, trying to teach and see patients is now responsible for 0.85 of a full-time FTE. Regardless of how much time they spend in clinic, they have to generate that somehow. And as of next year, there will be not only increases, but decreases in salary if you don't hit that target. It seems to me that they have stopped talking or not talked at all about the new changes in E&M coding, and perhaps will be surprised when some of my people get bonuses this year under the old plan that are higher than they had been for previous quarters, and maybe this will come back to bite us. But right now, I'm sort of in and please don't call my chairman. I'm kind of in a don't ask, don't tell mode because it seems to be benefiting some of my people, at least the last 2 quarters of this fiscal year. We'll see what happens in this new compensation plan in the coming year, where they've raised the targets for most people. That's all we have here.
Okay, and I noticed there are quite a few pediatric rheumatology division chiefs on the call. Have you guys experienced that you have to, some divisions I know are reimbursed on RVUs and others are not? Is anybody able to share their experience within pediatric rheumatology?
You want to raise your hand, I'll unmute you.
Any takers?
This is Vikas. I'm not a pediatric rheumatologist, but I'm at University of Mississippi, and my experience is exactly like Dave Karp's. They have been agnostic, and I've been keeping my mouth shut. And besides that, the FPSC is, and again, I do not know S, but their faculty practice something consortium. That's the model that our institution uses. And as far as I remember, about 4 years ago, this group came and talked to us at the division director committee meeting about their methodology and all that. It's really a hybrid of MGMA and AAMC calculations for RVU, and seems like a number of institutions use them.
This is Sangeeta Sule in pediatric rheumatology at Children's National. Same here. They haven't really addressed it specifically for us in pediatrics. I don't know if that's because there's just not as much data yet collected, but we haven't really been told about any changes yet.
This is Eyal Mustal, also pediatric rheumatology, Texas Children's, and I actually had a meeting with my practice administrator today, and it's as if it doesn't exist. We also don't really have productivity models. I mean, there's sort of you work for your cost of living increase during your annual review, but nothing has really changed at all, as if the codes have not changed, at least on our end. They also sort of funnel, I think, all the various benchmarks through Sullivan-Cotter is sort of where kind of our work RVU goals come from, which I have yet to hear how that sort of commercial entity sort of comes up with their national benchmarks.
So David Karp just suggested in the chat that perhaps we can do a white paper. I think that ultimately institutions don't want it known if they're disadvantaging their rheumatology faculty. But we want to find some happy medium between reporting the results as well as the qualitative interviews in terms of trying to identify, I think, what we think of as best practices and not best practices. I'd be interested to see how other people think that if we're going to talk about this and write a white paper on this, what the angle should be so that we advantage the most and don't disadvantage people who seem relatively protected right now.
Well, if I may, this is Peter again. Peter Merkel, I think at least our administrators actually are rational and respond to data, very data driven. I think presenting data can be useful. Comparative data with peer institutions, reputation, size, those type of things can be useful. We have many people on the call with different size, different types of institutions, so we need to be sensitive to that. The college represents everybody in rheumatology. But I think comparative data can be useful, and sort of learned inferences. Not everybody was born learning this stuff. Maybe Tim was, but I think helping us educate our administrators and our colleagues, they are our colleagues, and I think they will respond to data. And I don't know how to do it. It's not my area of expertise, but I do think that could be helpful. But it takes work.
Tim?
Yeah, I would just say, as I mentioned at the beginning of my little spiel, that I got this on the agenda for the next SAGSA meeting, and that's an ungainly acronym. It's a subcommittee, a socioeconomic subcommittee of ACP. I'm very interested, and basically all of us RUC types hang out there twice a year, and I will be very interested to see if all of the other ACP specialties are experiencing the same thing. So I don't know that we necessarily have to be the lead sled dog on this one. There may be possible to have a joint effort, and maybe under the auspices of the ACP. I don't know. I'm good at building air castles. We'll see. But I will be happy to report back after the SAGSA meeting at the end of this month to see if there's additional traction to be gained out there amongst other specialties, because I think there's other folks that are going to be disadvantaged. In fact, my colleague John Goodson just put out a health affairs blog, which showed that infectious disease doesn't really get to participate for whatever reason in a lot of these increases. And so, I think that if you look at the cognitive services as a whole, neurology, infectious disease, endocrinology, et cetera, I think we're all in the same boat. And I'm guessing that across institutions, we've had exactly the same kind of studied indifference, if you will, to what CMS has been proposing. And I think from my perspective, this is a pivotal moment in medicine in America. Not to be too hyperbolic about it, but this is a big deal.
other thoughts on things that should go into a white paper besides of a summary of the data and perhaps a summary of what we think might be best practices? This came up at a meeting with our division chiefs in Madison, and got disseminated what they were doing. So we now see both what we would have earned under the old RVU schedule and what we're actually getting an incentive under the new RVU schedule, and that's the only way that we've actually seen additional compensation. And so my chair, who's actually an ID person, I said, well, they're finally paying us what they should have been paying us all along. But I think that that's not widely necessarily held by institutions. And I think, I wonder if are there other chairs who've not been as much of an advocate for the cognitive specialties. We have both procedural and cognitive specialties, I think, in medicine or areas that have higher levels of procedures. And has that influenced anybody's experience, do you think? Does anybody have a gastroenterologist or a cardiologist as chair, and and how have they handled this? Okay, so talking about the, Joel, did you have something?
Yeah, am I muted?
Nope, we can hear you.
I just wanted to comment to the earlier point about the kinds of things ACR should do, and that is that the administrators, the administrative leadership of all of our institutions talk to each other. They are no doubt aware that they are all going about ways to solve their zero-sum game by not punishing the proceduralists and by actually punishing rheumatologists, which makes sense. We're a small field. So it seems to me that data alone is not what's going to be necessary. If the ACR wants to think about strategies that could be useful to rheumatologists, especially rheumatologists employed by institutions, which is now the overwhelming number of rheumatologists in the country, they need to come up with ideas that our administrative leadership will find compelling beyond providing data that all of their peer groups are also punishing us. I'm not sure that's going to be helpful in the long run. That's all.
Rich, you had something to say as well?
Yeah, a question. So at the institutions where they're manipulating these numbers, are the faculty protected by contracts? Just like we have 3-year contracts here that specify your RVU targets, the penalty number, the augmentation number, and on top of that, a restrictive covenant.
Well, we are protected by contracts, but our contracts, at least at Rush, refer to bonuses based on RVU targets, and the RVU targets are not contractually based. They're assigned every year.
Yes, our I think letters say something to the effect of that those will be calculated as decided by the department or something to that effect.
Yeah, same
Consistent
here.
with the department incentive plan.
Yeah. Same here, Rich. We have a contract, but the contract doesn't spell it out. We have a target, but they're sort of nominal because they moved to a strictly productivity-based compensation plan at Northwestern. And so it is strictly based on the RVUs you bring in for at least the clinical portion of your salary. And that just changes from year to year based on what you bring in. That sets your benchmark-based salary for the next year. But the dollars per RVU, which is how they're manipulating it, isn't spelled out in the contract. That changes periodically, which they say based on market forces, whatever that may be.
Okay, and I think, Chris, you said your contracts are annual, I'm seeing. Do you want to comment on how that works? Do you have to negotiate each year? I remember Joni Bathon, when she was talking about being at Hopkins, said that she had to do that every year. Ken, do you want to talk about what you just said in the chat box? Ken Sad, are you unmuted? Can we unmute Dr. Sad?
No, I'm unmuted. Thank you. I didn't see where the switch was. I'm on a phone in the car here trying to get home. Yeah, no, I think that is probably where this discussion needs to go. At our place, we generate $30 million a year in infusion revenue, and we see about 1% of it back. And, you know, all the discussion with, you know, the small increase in E&M-based coding is important, but it's, you know, to some degree a rounding error if we could get a greater proportion of the revenue back from our infusions, which is really the difficult discussion that we just haven't really been able to crack at UAB, but maybe other places are finding an easier pathway.
I know Chris Richland had some success at Rochester. Rich Fury, or you or anybody else, if you had success with that?
So our unit bills or our revenue for infusions is about 35 million a year. But it depends how the bill is generated. We don't do hospital billing. We bill as, you know, sort of community doctors. The money comes into the division and then the hospital takes it in some fashion. So we're taxed at 6% for every dollar that comes in, just to break even on the drug expenses. So there's not a whole lot of profit after you pay your tax and after you pay your staff and so forth. Now, hospital billing's a different story, but we have not done that. And I think that's a good move not to do it.
Our hospital does it that way, and we do not see on the P&L all the infusion revenue, but I've been able to calculate it at about 20 million. We're about a smaller place, and every time it comes up, I say, remember, pharmacy doesn't bring these patients in. But I've been unable to make headway in terms of getting the revenue to follow we have the expenses of the nurses, yet the revenue goes to pharmacy. So typically you'd like revenue to follow the expense, but it doesn't do that in this situation. Chris, you said that your infusion goes to the overall practice. And so that those are reinvested into having some help with the work in terms of getting paid for the infusions. Have other people who do hospital-based billing been able to share in the compensation margin at all?
I think there's, this is Peter Merkel again. I actually today, ironically, met with the CEO of 2 of our hospitals for strategic planning purposes. And we talked about our downstream, which is substantial with infusions, specialty pharmacy, and our usual work. There is a problem with actually getting a direct link back. There's some ethical issues, and it's not how we do it. I think it's more about recognition within the health system of the value we bring both to our patients, most importantly, and access, but also fiscally. I think I know ours get it. How that translates to the day-to-day with the RVU, though, is a different issue. I think this RVU issue creates anxiety for faculty, understandably, because of the uncertainty. I think it'll even out, but it doesn't help when you're up till 10 doing your epic and still have to worry about this. And so I think there's a disconnect there that we are all working on.
You're going to sleep early, Peter.
Well, you know. Then you start the grants. That's
right. So I think that it's become clear that, you know, the electronic medical record has extended our our days, and that at least our institution is actively working on ways to reduce that. And with the reduction in what you have to actually document, I think that has helped some. And I don't know if anybody else has had that experience. Rich, Eric, did you want to share something?
I'd like to ask her.
I accidentally have my hand up.
Oh, sorry. Christy?
I'd like to ask our speaker, could you speak, do you know which of the benchmarks, like does that double AMC benchmark assume that there is some infusion revenue? This is sort of the question that I've had is do any of these benchmarks include infusion revenue? No? Okay, so they're all just based on, okay, that's helpful to know. And then the second piece is we don't receive any of our infusion money, but the other piece that our health system is getting some benefit from us is that we have one setting that is eligible for 340B savings. So they've asked us to kind of use some practice sharing there, and that's certainly saving the health system money. So I don't know if anyone has any experience in that realm as well to see about a cost share model, or other than we are going to be able to, like Chris Lower, get a little more support from specialty pharmacy. But I'd love to hear maybe if anyone else has experience in that realm, maybe if that's within scope.
So we have exclusively a 340B or an outpatient hospital model, and we have a 340B program. I think that as infusions have become more and more expensive and patients more used to self-injectables, that we are now having probably less new starts than we did 5 years ago. But our hospital has also developed a specialty pharmacy, and I suspect that many of you are at institutions where there are specialty pharmacies, and that you may have been asked in a number of different ways to help with the specialty pharmacy. Is that anybody else's experience?
Yeah, we have a specialty pharmacy, and they net off of us a couple $1 million a year, especially on 340B patients, and they keep it all. But what we get in return is we get technicians in our office who do all the authorizations. They seek the approvals.
Allie, did you want to say, Elizabeth, do you want to say something as well? Can we unmute everybody and so that they can just chime in when they want to at this point?
That is a great idea. Let me see if we can do that.
Hi, and Steve Lindsay has a comment also. Do you want to, are you unmuted yet, Steve?
This is Ali Reza. Can you hear me?
Yes.
Okay, so I'm at Henry Ford. So we don't get any revenue of our infusion just because a number of the infusion actually is going down with the way the new medications, both the JAKs and injections are coming down. And so that's why we never want to have our salary be at risk of any infusion revenue, because then that can be adjusted immediately. And it's usually tough to renegotiate your previous salary. So that's why our institution, we get the whole discount for the medications, everything else. We do have the pharmacy advantage as our own pharmacy. We have HAP as our own insurance, but honestly, we don't get any credit from any of these things. Even if I order 400 different small molecules or injectable biologic, I don't get a penny or any credit of that. So that's our experience at Henry Ford. And by the way, we have to make 0.9 of our full FTE and to meet our salary. And there's no dedicated time for teaching. You have to make everything and then teach at the same time.
Steve, Lindsay, you
This is Steve Lindsay. I was chief at Osher here in Louisiana for 20 years and then tried to retire. And we had Dr. Espinosa passed away as the chief at LSU. And so I'm the interim chief at LSU while we're searching. So I'm just new to what's happening at the institution. But at LSU, the UMC bills for our infusions And none of it's passed on to the Division of Rheumatology or the department. At Ochsner, when I started, the infusion center was in 1999, 2000, and we did very well for 10 years. Took over and said they wanted to do hospital billing because they got so much more payment. They took it away from us. Initially, we got some money, but then they took it away. I had 2 people leave my department because of that. And to this point at Ochsner, they're taking all of the infusion money and not giving anything to the division. It's a real point of conflict. And so I wish we could figure out a way. I know that my colleagues in private practice are doing well, and they're also getting rebates. We talked to a person who was getting thousands of dollars of rebate just from one company for using their products. So I think that there's a lot of practices going on where people in private practice are getting reimbursed for this. I don't know that's showing up when you look at the MGMA or the basis of our salaries. They increased the RVU targets, didn't really change RVU reimbursement yet. So we'll see what happens at LSU. All this seems like things are coming to a head. And I agree with Tim that it's really something that we ought to try to work on and see what we can do to improve the situation. We're underpaid, and we bring in millions of dollars to either the specialty pharmacies that we deal with or the institutions that rheumatologists are not benefiting them.
Okay, so it seems like many of the institutions have a lot in common, and we probably need to come up with a proposal of what's most important to bring forward in a white paper. So I think we'll probably just need to discuss that. We have a division director committee meeting tomorrow. And so if you'd allow, we'll discuss that further. I will also send Tim Lang's grand round slides, which are a more complete version of what he presented today to Robin and Connie so that they can send those out as he volunteered. Tim, do you have other thoughts or comments you want to share with the group?
Well, I guess it's, this has been a roundabout discussion. I think that you're going to have to bring to a focus tomorrow, perhaps, which I think is, this is a good thing. My career in trying to fight for better reimbursement has centered around these efforts for a long time, and I'm particularly frustrated to hear that what finally happened with CMS isn't being reflected nationally. And I think this is a big deal because ultimately we have long recognized that our profession has been undercompensated, and this is unfortunately maybe a hard lesson for all of you who haven't been involved in the white knuckle bits of medicine up until now. But in the underbelly of medicine, there's this is a zero-sum game, as you've seen, and it's reflected in the politics nationally. It's reflected in the politics within academic centers, and I think it's a mistake to just accept it and to let people roll over it. Some of the changes that were being talked about a few years ago, alternative care models of various sorts, which would involve a lot of bundling, as you know, will ultimately be based on building block models. And if those building blocks are left to sit where they're at and they're not recognized, then we're going to continue to struggle with our workforce. And I think at this stage in my life and in my career, it's not about compensation for me, but it's about the sustainability of our profession. And so it's really important, I think, to create and to continue to be vocal in various venues, to be determined. And as I said, I'm planning on elevating this discussion in the ACP. because you all see every day what's happening with corporate medicine. And we've now crossed the Rubicon. Over half the physicians in the country are in employed models. And academic centers didn't start out as clinical centers, but they're engaged now in an arms race. And for us to be sustainable as a profession, we need to stake out a position that clearly states what our value is, and clearly states that you know, when a lot of people nationally have put their heads together and decided that there is a danger to the various workforces that involve cognitive care services, we have to have a voice. So I don't have a specific proposal here, but I'm endorsing where the direction that you're moving in. I think that's a very good thing.
So hopefully people have learned a little tonight, even the people who have a lot of knowledge. And I think that Eric said it in the chat, but how we address actually realizing the value of our cognitive services that have now been recognized by CMS, and having our own academic institutions recognize them also. It sounds like that's where we really can make headway, and that the opportunity to make headway over infusions that the hospital controls, I think, is less than the opportunity to make headway and be transparent about what we think should be happening at academic institutions, so that people are then educated, and when they look at positions, ask if that's what's happening at that institution. And so to me, that seems like something that we would want to do. So I was fortunate to be a fellow at Michigan, and so to speak, I've grown up with you ought to get paid for what you actually do, and Tim's mantra about that. But I think that not everybody has had the same education as I have all along, and so helping people to get there more quickly and ask those kinds of questions when they're looking at positions, it seems to me would be a natural place to start. Do other people want to have other comments before we wind down? Okay, so I'd like to really thank you for sharing your knowledge, Tim. And there are some comments in the chat also thanking you, and thanks to the ACR and Connie and Robin for supporting this and making sure that we got this on the books in a timely fashion.
Well, thanks for having me, and I appreciate your willingness to send out the slide set. There's some more juicy bits in the slides that you might enjoy.
Okay. Thank you. Good night.